So we're going to talk about, it's one of the first times I've given a presentation not on intracerebral hemorrhage, but this did actually come from intracerebral hemorrhage. So we'll talk about that a little bit. As Michael mentioned, I've got some research support and one entrepreneur endeavor. I'll start by acknowledging my coworkers and the people that really made this program possible. This first individual is David Petrino. He's a PhD and physical therapist who runs a lab called the Abilities Research Center at Mount Sinai. And he is the guy who takes new technology and applies it to recovery. And he's really been focused on neurologic recovery. And so we started joining forces about 1.5 years ago to build this program. And he's just a genius in applying tech to quantify human behavior and recovery. And he's been essential the entire way. And then Jenna Tosto is the program coordinator who makes everything that I'm going to talk about possible, running the day-to-day. And then, of course, Josh Betterson, who, when COVID happened in New York, and I pitched this idea to him, he basically said, just run with this. This is going to be the thing you're going to do for the next 2 months. So Jay Mako as well gave me that freedom to devote my time to this. And then Joseph Herrera is the rehabilitation department chairman, and he has been an amazing supporter of this program just every step of the way. And of course, I'm going to also acknowledge an old mentor of mine who I started doing research with when I was a medical student in 2007. I was working with Sandra Connolly, got involved in a number of clinical trials, and then it seemed like every clinical trial I was involved with all the way up until this year is Dr. Liz Kim is on that clinical trial. So, and then of course, Mike Levitt, whenever I have a question, personal or professional, I'm giving Mike Levitt a call, interrupting his cases and talking to him about it. But then some of you might not know that Rajiv Devsen and I did some work together for 1 year in Dr. Connolly's lab, published a number of papers there. You can see us on there together. And of course, this big recruit that you guys have coming in next year, really an absolute powerhouse, and pretty much made my career this year by coming out with a number of publications and developing a number of projects. So thanks to you guys. I feel out of place talking to you guys about coronavirus and how to respond to coronavirus because New York should be taking lessons from how Seattle responded to coronavirus. This is a New Yorker article from a few days ago, or maybe a week ago, talking about how because you responded so quickly and responded in a correct way, listened to scientists, things went pretty well compared to how we're doing over here. I'm going to show you some graphs on that. And then you can see in this comic here, New York has his hands in his ears. So looking at the US, this is from the New York Times yesterday, and this is constantly updating. So you can see how the US is doing in flattening the curve. We are still climbing in the number of cases we have overall. If you look at Washington, and these are not to scale, just to show you what the curve looks like. You guys had a bump there right at the beginning and got things under control pretty fast and really did flatten the curve. When you look at New York, we might have a little bit, but not really. I mean, it really was a surge that we felt. Many hospitals exceeded their capacity. Fortunately, the Mount Sinai Health System has 7 hospitals in the immediate New York region. So we were able to move patients around and move resources around in a way that no hospital ever was out of resources and unable to treat a patient, but it was very tight. And I'm going to show you some details about that. So what did this mean in terms of people dying? You know, some states are actually reporting that they're having fewer deaths than before COVID than would be expected. And this is also from the New York Times yesterday. They produced a report of every state and the number of deaths expected. And so you can see that Missouri and a bunch of other states, because they've been on quarantine, they haven't been having the usual trauma and other problems that might lead to ER visits and problems like death and would lead to death. Washington is doing pretty well, but has had a few weeks where they've had more than expected deaths related to COVID. And New York is just off the charts here. You can see that we've had 6,500, there are a few weeks with 6,500 weekly deaths in excess of what you would expect. So for New York, to put that in perspective from per capita and percent above normal, New York City had 323% more deaths than would be expected. Washington State had 9% more than would be expected. Everyone's become familiar with this graph, and this graph is really kind of what inspired this program and inspired David Petrino and I to pivot this program to address COVID. And that's why we're talking about this here today, is that everyone was discussing how do we flatten the curve so that the same number of patients who become ill over a long period of time and don't exceed the healthcare system capacity. There was a really interesting article kind of right when the beginning of all this flattening the curve discussion hit mainstream. And it was talking about adding to that, not only are we flattening the curve, but we're trying to flatten it in a way that we're able to respond in time to be able to meet the peak of patients. Even if that peak is above our current ability to treat patients, it might not be above our ability to treat patients after we get all the resources we need to get things done. And so what David Petrino and I were thinking is, what if we are able to, in addition to increasing healthcare capacity, increase healthcare efficiency? And we think that if we can increase healthcare efficiency, we can take this line here and increase it even faster, even earlier. And so this concept is an idea that there are many patients with COVID in the community, and that's here on the right here. So many people are healthy. Some of them are sick with COVID, and some of them are critically sick and they need to come into the hospital and be treated in the hospital. If people are left to their own devices and their own decision-making, they don't necessarily have the expertise to know when they need to come in and when they need to stay at home. Some people are staying home unnecessarily when they really need to come in, and some people are coming in when they really should have stayed home. So if we can manage that decision-making, we can optimize the efficiency of the healthcare system and keep the right people at home and get the right people into the hospital. And so the concept is that we can do that with an app that tracks patients' symptoms. Do we really need this? In mid-March, Cuomo, the governor of New York, implemented this 10-point plan. And if you look at point 8 of the 10-point plan, this was actually in the government. There was a recommendation that you shouldn't leave your home unless to receive medical care, and only after a telehealth visit to determine if leaving the home is in your best interest. So everyone agrees that people need medical professionals to make the decision of whether or not they need to come in. And we should maximize the technology we have to make that happen. Right from the beginning, our ERs and our hospitals were overwhelmed because it wasn't clear for patients when they needed to come in. What constellation of symptoms make a patient need to come into the hospital? You know, it took even us a few weeks to a month to figure out what that exact line is. And of course, that line changes as the resources in your healthcare system change. So some patients are coming in unnecessarily, other patients aren't coming in. This is a paper that my colleagues and I published last week reporting large vessel stroke occurring in young patients. And the last paragraph of that article, to rapidly communicate information on global clinical effort against COVID, the journal, sorry about that. That did not, oh, there we go. Social distancing, isolation, and reluctance to present to the hospital may contribute to poor outcomes. 2 patients in our series delayed calling an ambulance because they were concerned about going to a hospital during the pandemic. You know, I was on call and I treated one of those patients. It was a patient who could have gotten thrombectomy and didn't, and ended up getting a hemicraniectomy as a result. So some people are staying home because there's a coronaphobia, and some people are coming in unnecessarily. Our hospitals were quickly overwhelmed. I'm sure you've seen these pictures. This is Central Park, and a tent hospital that was put up there early in the crisis. Every hospital had an adjacent ER surge tent, and some of them had multiple ER surge tents. Each of these basically have kind of one bed for each of these areas right here. So about 10 patients can be seen at a time in each of these. And that's used for pre-ER triage for any patient who seems like they might have COVID. They go in that tent, they get evaluated, then they go in the ER if they're going to get admitted, or they go home. And we even had to increase capacity by building rooms in the lobby. So this is the lobby of Mount Sinai Hospital. On the left here, you can see the room structures going up, and by the end, the entire lobby was completely full of basically an entire new floor of rooms for patients. And we were also making space by doubling up. Some hospitals had to double up with 2 patients or more on a ventilator. We were doubling up with 2 patients in an ICU room. So every ICU had 2 patients in each room. And of course, after a patient leaves the hospital, coronavirus is not a one and done kind of virus. I'm sure many of you who have known people who have had this and seen it clinically. You know, a lot of people have this course where they become ill, then get better again, then become ill again. So there have been many patients who have recovered from their hospital course and then had other problems at home, either a resurgence of symptoms or an additional complication as a result of having the disease in the first place. And so this is an article that was in the New York Times about 2 weeks ago, reporting that 4 patients who were in a hospital system in New York had gone home and they were getting monitored at home by phone calls, but they had still missed their phone call appointments and had passed away for various reasons. So what can we do about that? And how can we implement a service that will better track patients at home, after they leave the hospital, after they leave the emergency room? So here are some general numbers about how many patients are coming into the hospital, and from those, how many patients need to be admitted and don't need to be admitted. So these are based on numbers from China, and this was our original concept when we pitched this to the hospital and to the leadership of neurosurgery and rehab. About only a third of patients who were presenting to the emergency room with COVID or COVID-like symptoms were getting admitted. The other 66% is getting sent home. And so we evaluated what our access to pulse oximeters was, which are their limited resource, especially when everyone in the country is trying to get them. And there's also some cost associated with them. So we made the assumption that we would not be able to give them to everybody. So we identified 2 groups, a high-risk group, and sorry about the typo there, but a low-risk group. And the actual high-risk group is 1/3 of the patients who are not getting admitted by our estimates, and the low-risk group is 2/3. And so we set high risk at age 65 or older, and having any comorbidity that would put a patient at risk for severe COVID disease. And that would be a pulmonary complication, pulmonary comorbidity, cardiac comorbidity, immunologic comorbidity, a renal comorbidity, or hepatic comorbidity. So if you're young and you have asthma, you're still gonna be high risk. And why that matters in our program is because patients who are high risk are going to get a pulse oximeter, and they're going to report their data twice a day. And patients who are low risk are going to not get a pulse oximeter and report their data once a day. So the patient enrolls in our program. They download the app that they're going to put patient-reported outcomes into. And then if necessary, they also get the pulse oximeter handed to them in the ER or in the inpatient ward before they get discharged, or they get mailed the pulse oximeter if they've contacted us from home directly, or they got referred through a virtual care service. So they never set foot in the hospital. And then the hospital actually donated a van for us to deliver these to patients who are in the Manhattan area if they didn't get them in the hospital, or if they contacted us and never made it to the hospital for whatever reason. So then once a patient's at home and they are reporting their symptoms daily, if they report worsening of any symptom, then our provider who's caring for that patient and monitoring their data calls that patient on Zoom and does a 5-minute, 10-minute Zoom call, evaluates how the patient's doing. If that provider, who's generally a advanced practice provider, physician's assistant, nurse practitioner, nurse, or physical therapist, if they wish to have an MD added on, we have an MD on call 24/7. A lot of times it's me, but a lot of times it's not. And then that person gets the Zoom ID and just jumps on the Zoom call with the provider and the patient and makes an assessment if the patient needs to come into the emergency room or not, or if they need to have some kind of additional escalation of care. So when we came up with the idea to pivot this pre-existing project, and I'm going to talk about how it was pre-existing project that was right here on March 16th. So because we already had the protocols in place and legal had already blessed our app and information security had already blessed it for other purposes, we were able to quickly pivot and just immediately start enrolling patients. So we were fortunate enough to be able to get going and before this whole surge happened. And so we were implementing and rolling out in each of the ERs and inpatient areas really right from the beginning. I'm going to take a step back and I'm going to talk about where this came from in the first place. And as a stroke neurosurgeon, I care about stroke outcomes. And as an intracerebral hemorrhage neurosurgeon, we have not succeeded in clinical trials. And so one main goal of my job as the program director for the intracerebral hemorrhage program is to figure out a way to improve patients' outcomes with ICH. And so we have been hampered for decades by a very blunt outcome measure. Every stroke trial uses nowadays the modified Rankin scale. And so this is a very blunt 6-point scale that lets you know if the patient is perfectly fine at 0 or dead at 6 and pretty much incrementally impaired more and more throughout that. With that scale, many trials that seemed favorable with preclinical data and with in vitro data didn't work out. And so one reason a lot of people think those trials didn't work out is maybe the outcome measure is just not granular enough and can't detect difference when a real treatment effect is there. It also doesn't include time. We decide that 6 months is the outcome time point, but what if patient A who got the treatment got better at 3 months and patient B who didn't get the treatment just got there at 6 months? Then you had that 3-month window of improved function in the person who got the treatment over the person who didn't, but you don't detect that in the difference. So this program is originally and will ultimately be again an effort to devise a more granular and time-sensitive outcome measure. And so how David Petrino and I came up with the plan to do this is we would use daily patient-reported outcomes through this app called MyCap, which is a mobile version of a website you're probably familiar with called RedCap, and Zoom. Zoom because it's freely available and it's easy to use. And for stroke patients, we were giving them a blood, and we're following their blood pressure daily and giving them a weekly video visit. It's only 5 minutes just to review their data for the week. And then on that video visit, we would do a neurologic exam and we would record their neurologic exam. And I'll show you some of that information. And the reason we're doing that is because one of the major predictors of a second stroke or readmission is poor control of blood pressure. In this very recent trial, just from a few weeks ago, these authors showed that intensive blood pressure treatment after stroke can reduce the chance of another stroke by 22%. So there's a very solid medical reason in neurosurgery and neurology to follow patients closely after they've left the hospital, instead of having them come back for their 1 month, 3 month, and 6 month and follow up with a PMD. Taking some ownership over this very specific outcome point and keeping track of that, because this is a really clearly actionable physiologic measure that just daily monitoring can help. Even just the patient seeing what their blood pressure is can help to implement behavioral changes. So I mentioned we also take a video. So we're also taking a video of patients weekly and guiding them through a neurologic exam. So this is, make sure this works. This is an automatic kinematic software that David Petrino wrote that identifies pivot points in the body and then can quantify the movement. So we have a provider guide a patient through a neurologic exam, specifically the NIH stroke scale, and then the software automatically grades the patient and gives us obviously we're not doing sensation, we're not doing hemianopsia, we're doing everything that we can do with the patient moving. So we're doing both arms up, we're doing right leg up, left leg up, we're doing smile, having the patient speak into the Zoom, and then having their voice evaluated and answer the level of consciousness questions. And then reach out to the camera for dysmetria. So we're able to get a pretty good neurologic exam through telemedicine. A year ago, this was it's not an acceptable way to follow a patient. Nowadays, with telemedicine nearly completely replacing follow-up, at least in the short term, now it has become increasingly more relevant. So how do you pay for the blood pressure cuff, and how do you pay for the staff to follow these patients? And this is something that is really what makes this program possible, and even might make this program make money for the neurosurgery department or for the internal medicine department or whoever is monitoring these patients. There's a pretty good incentive to do this. And in January of 2019, CMS had what I think tremendous foresight to implement this set of codes, which allows somebody to report data, which can be symptomatic or physiologic data, into an app and have that stored in the cloud to be reviewed by a physician or a physician's team later. And so you can see that, you know, these are small amounts of money, but if you're monitoring hundreds of patients, this really adds up. And what is really fortunate is you have this initial onboarding code. That's not very much. That's your initial conversation with the patient describing the program. And then you actually have this kit supply code. So you're able to support an app and, you know, the monitoring of the app and the maintenance of the app, and you're able to support giving a device to a patient, as long as that device is not hundreds of dollars, you know. But if it's a $25 blood pressure cuff from Amazon, or it's a $25 pulse oximeter from Amazon, that's totally fine. And then if you outsource those even better, you can get those prices down to $15. But the codes for the kit supply give you $60. And then if you monitor a patient, you get $50. And that's for 20 minutes. And then just in 2020, in January, CMS came out with the second code for monitoring that allows you to monitor patients more than 20 minutes. And so each of those additional 20 minutes is another $40. And that is, you know, a result of patients need more than 20 minutes to have their monitoring, and then for you to have a conversation with them once a month about their blood pressure. So that was acknowledged that some patients are more complicated than just 20 minutes. And I think that was tremendous foresight to give people, you know, motivation to give the adequate care. And then the video visit weekly that we do is also a billable service. As long as the patient hasn't encountered any E&M services, you're able to bill another $20 for that brief video visit. So that's how it becomes a financially viable solution. And let's get back to the issue. So in March 16th, we started implementing this plan. And we went from giving patients the blood pressure cuff, which we had been doing for stroke patients, to giving them a pulse oximeter. And so why we're giving them pulse oximeter is that I'm sure that many of you have seen a number of articles come out recently talking about the value of the pulse oximeter in COVID patients, because some patients will have worsening lung function and increasing dead space prior to suddenly decompensating. You know, and there are many reports of people arrive into the ER and then 2 hours later get intubated and going to the ICU. That is something that we're trying to obviously avoid in the home. And the pulse oximeter, when you're face to face with a patient on Zoom, and that patient is breathing quickly, telling you they feel short of breath, but able to finish a sentence and able to move around, you know, it's a tough call. Should you send that patient in the ER or not? As a neurosurgeon, that's never a decision I thought I'd be advising on a patient, but nowadays that's what my clinics consist of. So the pulse oximeter can be an essential piece of information, and we're giving it to elderly patients, not elderly, but over 65, because they're the ones who are most likely to need it. More recently, we actually got some philanthropy, got some more pulse oxys, so we're able to decrease that number to 45. So we're actually giving, at this point, pulse oxys to every patient who's 45 years old. I'm just going to show you a few details of the app. The critical thing here is that this is not complicated. We were going for as simple as possible, and maybe that's just my excuse for it not being that great. But we just wanted to make it something that everybody could do without any complicated bells or whistles. It's not connecting to the pulse ox through Bluetooth. It's not automatically sending me the data from the pulse ox. It's just a patient-reported set of questions. The first time the patient signs on, they are prompted to enter a number of questions about their medical history. You know, not too many, like 10 to 15 questions. We've been adding some throughout the time, so that's why I give a range there. And then they're prompted to answer their first set of COVID-19 questions, which are about 12 questions that ask, basically go through every symptom that has been reported to be associated with COVID, and then ask people to rate their severity of that symptom. So the most important one that we really focus on, of course, is are you experiencing shortness of breath? It's the one that's most likely to get the patient into the emergency room. And then we also ask them to rate that shortness of breath on a 1 to 4 scale. If they have a pulse ox, then they're also prompted to enter their data. So sorry about the typo there, but then they enter their pulse rate and they enter their blood oxygenation. We ask them a bunch of other questions: chest pain, anosmia, loss of taste, blueness around the lips, looking for cyanosis, difficulty concentrating, headache in the morning. And we also ask about anxiety. I think that one thing I've learned about this program is that from this program is that everybody who has COVID is anxious about what's going to happen. And because the fear, there's so much fear about it, about young people having problems, you know, we're partly guilty about spreading that fear from that LBO paper. Some people, knowing young people who got very sick and maybe even passed away. I'm sure some of you might know that a very young nurse in our hospital passed away early on in the crisis. And that was really a devastating thing for everybody involved. So everyone does know a young person who's gotten very sick. Even young people getting this who are doing well are getting very anxious. And we're really seeing that play out in the surveys. And then of course we're asking, would they like to be contacted? There is a chat mechanism in this app. You know, in the top right here, you can see there's a little chat box. So that allows a patient to chat directly with us. But we also ask them if they want to be reached out to, and then that will initiate a Zoom call with the provider. So provider, an advanced practice provider, is looking at these responses on a daily basis. And then if they see any change whatsoever, any worsening, that initiates that Zoom call. This has produced a really interesting data set that allows us to see what is happening to people at home with mild COVID. If you ask people what's happening with severe COVID, everybody knows. A bunch of papers have come out. But for the other 95% of the people who are getting infected and spending time at home, what's happening to them? What's their course of illness like? You know, and nobody has produced that data yet. And so I think this type of home monitoring allows us to understand the disease in a way that we would otherwise not be able to. So this is the, let's see, it's cutting my screen off there, great. So this is the chance a patient is going to pass away based on age. So this is mortality based on age. And the reason we chose 65 is that seemed to be really where it was starting to jump up. And then the reason we bumped it down to 45 when we had the means to do so is that we wanted to catch this group here. Here's one of the best symptom charts that exists in the literature. And this is from one of the early papers from China. And basically they showed that the average time to admission was 7 days after symptom onset. I'm sure you've heard everyone talk about. You'll seem like you're doing well for about 7. You'll have a few days of fever, then a few days where you seem like you're doing well, then really crash at 7 days. And so this paper showed that the average time to admission was 7 days. The average time to experiencing dyspnea was 8 days, and the average time to having ARDS for patients that were admitted was 9 days. The average time to getting into the ICU, median, was 10.5 days from symptom onset. This other study from China looked at what's the difference between patients who die and patients who don't, and their symptom course. And when you look at this, it's depressingly similar, actually. You know, the fever seems to occur for about the same amount of time. The cough seems to occur for about the same amount of time. The dyspnea seems to start right at the same time. So when you're trying to differentiate between somebody who is going to do poorly and somebody who's going to do well, it's actually very hard to do that with the initial symptomatology. There are many groups who have talked about symptom tracking. And however, I just want to point out the difference between symptom tracking in a remote patient monitoring program and symptom tracking for research purposes is that you're actually using the symptom tracking to make a medical recommendation, and then you're billing for it. It's an actual medical service. So I often hear or am asked, how is this different from this or that symptom tracking app? And I think all the symptom tracking apps are critical because we will then understand the course of COVID at home. But there is a critical difference that remote patient monitoring is actually a service. So the way we develop this platform is that we've got 3 tiers of people involved. And tier 1 is the coordinator tier. And that is a group of 8 to 10 people right now who receive the incoming calls and then assign a provider and schedule a Zoom visit with a provider and a Zoom visit with a physician. If a patient's already a Mount Sinai patient, we don't initiate a new Zoom visit with another physician. But if they have never been seen at Mount Sinai, then we have a physician see them first. That physician establishes a medical record and goes through the medical history and drops a note, and the providers can refer back to that. This is just how we do it in the emergency room. Just kind of give you an idea of going through patient enrollment and that flow sheet. So once the ER identifies a patient who's come in, and anyone eligible are patients who are symptomatic from COVID or symptomatic for suspected COVID, even if they had a negative test. That's still somebody who might have COVID and should be tracked. Or if somebody has imaging findings consistent with COVID. So we then hand them the flyer, and our flyer that we have has a hotline number on it. They call or text the hotline number, and then that activates them in our system. And we have our coordinator talk them through onboarding and talk them through downloading the app. That is really the hardest step of this whole program, is getting somebody to download the apps effectively. So we try to make direct contact as fast as possible and work through that. If a patient doesn't have a smartphone, then we just call them every single day. Obviously, they can't be billed through remote patient monitoring, but just trying to keep tight tabs on everybody, and we ask them those questions. Actually, 30% of the patients who we've been monitoring don't have smartphones, so that's kind of a surprising stat for me. That's been coming down over time as we have new ways for patients to enter the program, but that was our initial look at the data. And then a patient has to verbally consent to the program. It's not research, so they don't need to sign a consent form, but they do have to state that they understand they're going to be monitored at home, and then that has to be documented. And then they get discharged home, and they have now their pulse oximeter if they fit the criteria. They have their 2 apps, and they're going to start entering data on a daily basis. A lot of hospitals, and I'm interested to hear what you guys are doing for patients who have COVID and then go home. But a lot of hospitals are doing this plan, and this plan is what Mount Sinai initiated doing before we added our program to the mix. And transitions of care is kind of an ideal group to manage this, because they're already calling patients within 48 hours of leaving the hospital, and they're already calling patients a week after leaving the hospital. This is a standard medical billable service that's been around for a little while, and kind of ensures that as a patient moves from hospital to home, they have the right medication, they have the right equipment at home, they got their physical therapy appointments, and that's really a critical service. So in our hospital, that group took over managing the outpatient response to COVID from discharge. And our hospital also developed this text-to-chat platform where if a patient has a question, they can text a question to this text-to-chat number, and then they'll get a response back from the bot. And then if they exceed the bot's ability to respond to their questions, then it'll get bumped up to a healthcare provider. And then this system really tries to emphasize that there should be a PCP telemedicine visit at week 1 and week 2 after discharge. So our program kind of runs in the background of this. And initially, there was a lot of concern that we might be competing in time or billing codes. But the truth is that the remote patient monitoring is completely separate from the billing codes for TOCC for transitions of care. So there's no conflict there. And as long as in remote patient monitoring, you don't bill for that video visit at 1 week, because there are other E&M visits within that week period, then there's no conflict with any of the billing. And it gives you the ability to monitor a patient continuously, rather than having that patient reach out to you if they have a problem, and rather than putting the onus of them to diagnose themselves and decide if they have a problem. You are continually monitoring their symptoms on a daily or twice daily basis. So you're kind of flipping the responsibility onto the healthcare system, keeping tabs on that person who's gone home, rather than them being responsible to reach back out. And that's something I think is really critical, because you want to manage the patient flow as much as possible, keeping people at home and getting people back if necessary. So there are 4 ways you can get a patient into a remote patient monitoring program. We initially thought this is going to be something for the ER. Patients are going to come into the ER with COVID, and then they're going to go home, and that 66% going home, we're going to capture them and monitor them at home. But then we started getting some real champions on the inpatient medicine service who started pushing this. And we saw that actually, because the hospital's full, some patients have to go home on oxygen when maybe they wouldn't have gone home 2 months ago. You would have watched them for a few more days in the hospital. So you have to make some discharge triage decisions that you otherwise would not have made. And this comes into play there by giving a tight follow-up that's even more, has higher resolution than transitions of care and a 1-week follow-up with a telemedicine visit with a PCP. This is a daily follow-up and check-in with the patient. The patient's inputting data, and then you're checking in with, you're initiating call with them if they report worsening data, or if they don't report data at all, then you also ping them and ask them to input their data. And then virtual urgent care. Obviously, this has picked up enormously. Been a ton of papers on this. And when COVID happened, everyone was advised to initiate an urgent care visit from home if they feel like they need to come into the emergency room. Even when I had COVID, that's how I went about it. And now, as a result of that, I've become familiar with the system. And then later on, when my son crushed his hand in a door, we just went to virtual urgent care, and they talked us through it, and I didn't have to come to the ER and just managed at home. So it has made telemedicine more accessible. And so early on, we paired with the virtual urgent care at Mount Sinai called Mount Sinai Now, and they discuss our program with every patient seen who has COVID symptoms. And then they send us that list, and then we email blast on a daily basis that whole list of people who saw the virtual urgent care. So that has become a very large referral source for the program. And also a way to keep those patients continuously looped in to the healthcare system, rather than relying on them to reach out to virtual urgent care and see a new doctor every time. They have a provider that they're familiar with from seeing them on a daily basis. And then, oddly enough, social media and press started becoming a large referral source as well. And so the way that works is, because the interstate telehealth laws are relaxed, we're able to perform the service interstate. And so there are patients all over the country in this program as Mount Sinai patients, even though they are in Michigan or Florida or Washington State. It's kind of a strange phenomenon that I didn't expect, but at least during the crisis, we're going to continue doing that. And it's been interesting, kind of trying to coordinate patients getting into hospitals or getting 911 from other states. Kind of a problem I never expected I would be addressing. Here's looking at all the patients we've enrolled so far. This is the breakdown of how they got into the program. 14% through virtual urgent care, 18% direct contact through media, and then 29% were inpatient, and then 39% were through the hotline. That was what I was showing you from the ER. Here are the daily enrollments from April, and you can see that it kind of matches the COVID curve a little bit, and there's a weekly dip on the weekend. I'm going to show you a little bit of data from the patients who we've been monitoring. So far, we've been monitoring 700 patients, and here's the age distribution. 46.7 is the mean age. Here are some of the comorbidities. So, fortunately, most patients are very healthy and they don't have any medical problems, but some patients do have medical problems. So we are actually managing some patients with cardiac history, with respiratory history, immunodeficiency history, and other past medical history. Some patients get better in a few days, and then they stop being monitored in the program, and that's great. A lot of patients end up being monitored for a very long time, and some patients now have been monitored since the first week, which is now putting them at 7 weeks of monitoring. So it's a really interesting disease where some people do great, most people are asymptomatic, but there are this group of people who, whether they had comorbidities or not beforehand, are suffering for weeks and weeks, where they have symptoms that resolve and then have new symptoms in this kind of wave phenomenon, where they have a few asymptomatic days and then really feel terrible and kind of maybe have a new type of symptom, where they had GI symptoms initially, they might get better, and then they have respiratory symptoms. and then they might get better, and then they have further respiratory symptoms that are even more concerning. And so we have sent a number of people back to the emergency room or into the emergency room the first time who had severe chest pain that they developed on day 40 of symptoms. Seemed like they were doing great, had no problems, and then all of a sudden now, 40 days in, they're getting severe pleuritic chest pain or what seems like cardiac chest pain, and we're sending them into the hospital. Here's our breakdown of what symptoms patients are having and reporting. Concentration difficulty, headache, tachypnea, chest pain, shortness of breath. All very common, but not necessarily all together in the same patient. It's a wide variety. I think one thing we've learned is that this is an extremely variable disease, so that some people experience just one symptom and that's it. They just get anosmia and then they're fine. Some patients experience just GI symptoms and that's it, and some experience just respiratory symptoms and that's it. It's highly variable in the types of presentation you get and in the time course. Since we started with the program, we have monitored, sorry, this was in April 19th. So at April 19th, we've monitored 522 patients, and that produced about 6,000 days of data entry. 125 times we escalated care from the data itself to the provider. That's where a patient reported any worsening that led to the provider contacting them. 40 of those times, the provider added on an MD to that call, and then 15 times we instigated the patient coming into the emergency room. 2 emergency room visits, when those patients arrived, they were in critical condition, and there's from the teams responding to us, their situation was dire and they would not have made it if they had not come in, was the report. So there are two situations where we can very definitively say that those patients would not have made it if the program had not intervened. But I think on the flip side, the vast majority of the work that's done by the program and the benefit is in keeping patients home who do not need to come in and are extremely anxious about their disease. And you provide education, talk about the symptomatology that's expected, and look at the data from the pulse oximeter and the blood pressure cuff and thermometer if they have it. And that usually really does a world of benefit. Working with the rehabilitation department, we've also developed a curriculum for people who are recovering. And the fortunate thing about our providers all being physical therapists is that they can bring the patients through these exercises. And it's really, people are giving extremely positive feedback about breathing exercises that are very specific. Sorry, one second. Am I still screen sharing there? Yeah. Yeah. So people are giving very positive feedback about that exercise curriculum. Something that I didn't expect to come out of this, but it's an interesting advantage. And then what about all the patients who do not have COVID, who are at home and afraid to come in the hospital? We're seeing now that we're past the peak, the ER attendings and residents are doing less work than they were doing before COVID. I'm sure that's the situation you guys are having at this point. And so there are lots of patients who are at home with diseases that need monitoring that aren't COVID. And that was actually our original intention with this whole program in the first place. So we've actually increased our number of neuro enrollments since COVID started as a result of people needing home monitoring. If they had a stroke and they completely recovered, sometimes the team doesn't want to admit them to get their echo and to do other work that could be done as an outpatient. So they get sent home and we do twice-a-day monitoring for those patients. Here's what we're looking at now. We're coming off the backside of the curve. This was a few days ago, but now we're down to 800 patients in our healthcare system currently with COVID. You can see at the peak here, there were about 10 days where we had over 2,000 patients in the healthcare system, but now we're well down into 800, which is you can really feel the difference there. This is the percent change of inpatients with COVID per day in the Mount Sinai system. So for a while, we were really picking up the number of patients in the hospital. And then now for a few weeks, we've been steadily decreasing by about 5% per day. So what else comes out of something like this? After you've built this platform and patients are reporting data, then you can add other devices. And there are a number of really interesting devices that do for different types of monitoring that actually have different billing codes. This is one single lead EKG continuously connected device called the Zio that can provide some rhythm data and can provide some heart rate data. So initially, they contacted us to pair with us to collaborate and give this for free to patients who were getting hydrochloroquine. And so watching for long QT syndrome. And that's been a really fruitful collaboration and kind of an interesting side note. And so our plan when we really get this one fully implemented is to give this to any patient with a cardiac comorbidity. Also, when you have a group of patients who have COVID or suspected COVID and they're at home, they really want swabs and they really want antibody testing. And so we have paired with the Mount Sinai antibody testing group. And this group has already tested thousands of individuals. So they've got experience doing this. This is not the test. They're not doing a rapid test. They're doing a blood test. This is the picture I found online. And so we are working out a way to get this service to patients who are in the program, whether or not they're patients in the hospital, but to have them come in, get the test from home. And so that clinical collaboration has been really interesting. And then research collaborations, research groups want access to this patient population. And so a number of research groups have contacted us, and we are now doing pre-screening for interest in research. And if the patients are interested in research, then we send that patient over to the research team that that patient is eligible for. And one really cool study is a randomized study giving some patients CPAP at home. So that's also been another benefit to this home monitoring program. And then more broad applications, bringing it back to what I love and is intracerebral hemorrhage and trying to figure out a way to make these patients better. And so creating a platform where you can more granularly measure how these patients are recovering could one day develop a better way of evaluating their outcomes. I just want to acknowledge the team again. These guys are, do far more work on this than I do and have been amazing. And then all the support we get from the institution. And at this point, I'll take any questions.
Any questions for Chris? Go ahead, Mike.
This is Mike. So Chris, just awesome, awesome talk. And I remember when you contacted me, it was months ago before the world started ending, about this program and how you were really looking to spend a lot of time of your own time and resources on this, and just in regard to stroke. And it's just amazing that you caught the wave before the wave even happened. So, part of the great idea is having a great idea, and part of it is luck or timing or whatever you want to call it. And it's just amazing that you've been able to do this. I had a couple of questions. First, I think one thing that you had mentioned that maybe has gotten lost in a lot of the discussion, but you had tried to signal it out, is there's a difference here between this and other home health monitoring sort of programs that have happened in the past, and that is that you're billing for this. So this is a source of revenue that will support the program. Much different than, like, wouldn't it be great if everybody downloaded an app and then in the end you still need to do something with those data. But I was wondering, two questions I had was, number one, what is your end point for patients participating in this program, either COVID, or if we forget about COVID for a little bit, for the post-stroke patients, what is the end point, or how long are you planning to monitor them? Or is this the type of subscription service that could theoretically go on indefinitely, in which case it could be potentially a pretty big revenue stream for a hospital? That's one question. And then the second question, probably more relevant in the current crisis, is what do you think was the biggest pain point in implementing this at the scale that you have with 700, 800 patients, the hardest thing to overcome when you first got started?
Yeah, so I think remote patient monitoring, addressing its long-term applicability. For COVID, we've been asking patients to commit to 28 days of monitoring. I entered the program myself when I became symptomatic, and then I stopped entering my data after a week. But we ask patients to enter data even when they become asymptomatic, and at least just note that they're asymptomatic. And then we schedule a 28-day follow-up visit where we ask a number of other outcome questions. And remote patient monitoring codes require that you have at least 16 days of monitoring. So if a patient exits the program before 16 days, you can't do any of the billing. So that's kind of one minimum that you really have to hit. Patients in the program appear to be symptomatic until about 21 days. So there's a good reason to monitor them for at least that long. And there have been some longer. So we chose 28. Thought a month sounded like a reasonable number, and it would capture the 2 standard deviations above the average time patients are symptomatic after being enrolled in the program. And then if a patient's longer than that, great. And there are some patients who have been monitored for almost 2 months now. So, and at 28 days, if a patient likes the program, and most of them do seem to really like it, because it gives them contact regularly, then they're able to convert over to chronic disease management, which is blood pressure, cough, mostly, but if they have a pulmonary problem, then also pulse oximeter data, and other symptomatic data. So we have built out a bunch of modules for different disease processes. And if a patient fits into one of those, then we offer that chronic management to them, and we communicate with their primary care doctor and their specialist physician and let them know that this patient's been enrolled in this long-term monitoring program, and that data is going to be available to them. I think the most important thing is to not take responsibility for the complex disease management that really needs to be the primary physician or the specialist physician for that patient. But you, in that kind of case, provide a data monitoring service where you either just provide the platform and give all the data and all the contact off to that specialist or primary care doctor, or you provide the platform and the baseline of communication. There are even some hospitals who already have this in place where they have a nursing service doing the data monitoring and then also the patient contact. And then if there's any issue whatsoever, they bump it up to the MD and they say it's their responsibility to follow up with the patient. So the ultimate long-term goal in the pre-COVID times, and now looking forward to some post-COVID era, is that using this as a chronic disease management service. And that was the original intention from CMS. And you're right, that is really where you could see profit from this program. With a patient enrolled for a month, you're probably not going to see profit. But with a patient enrolled for a year, you will start seeing some profit if you have a few hundred patients. So there's a financial benefit to a patient being in long term. And really, it's kind of essential to fund the program, because you have to keep that nurse busy or that on staff to pay their salary to do all the monitoring. Second question, can you repeat that?
Yeah, what was the biggest pain point in getting it implemented?
Yeah, I think that really every step of the way, someone has an idea. I mean, this idea has been around, and we've been talking about it for a little while. You and I were talking about it. So everyone kind of has an idea about doing this, and it really comes down to just actually doing it. So just actually doing it, we ran up into a lot of problems with other people who were doing similar things or saying they were doing similar things, and we had to just kind of keep going. And fortunately, we were able to roll out quickly that allowed us to do that. So I think that perceived conflict with other groups who were actually not doing the same thing, but thought it overlapped, was probably the major initial roadblock that we were able to kind of part luck and part just having the resilience to just continue going when it seemed like we were meeting up against some increasingly powerful people who were doing quote similar things, but it really turned out not to be. So that, and then that I would say is an equal problem to actually managing all these patients. And managing all the patients is really only became possible because this enormous pool of providers became available who were quarantined at home or not on the front line because they were elderly. And so that made it possible for us to monitor all these patients. And we didn't have programming. We just had this patient-reported outcomes app. So we really threw bodies at the problem. And by having a huge staff that fortunately were volunteering their time to make this possible, we were able to just kind of crunch through and have a lot of human contact in the program. So now I have some anxiety we have to make a second edition of the app that runs automatically as our quarantined crew goes back to their regular jobs, which is happening in the next few weeks. So we saw that really right from the beginning, and we started working with an app development team. to improve this and automate it. And we basically have to build this whole thing before we land in the immediate future, or we're going to crash.
Chris, this was ingenious use of your academic time, so to speak, and taking advantage and extrapolating to the future. Doing this for stroke patients is going to be very useful. I just hope you keep up the energy that you've shown doing this despite having COVID. It's really quite impressive. And during this whole time, may I add, you wrote a New England Journal article on COVID and strokes. So I want to congratulate you for that, because that was the first piece on this very mysterious stroke syndrome that occurs during COVID. So you've been pretty busy. So congratulations. That was an outstanding talk, wonderful job, and I really appreciate you spending time with us. We tip our hat to you, and I'm looking at my University of Washington Medical Center crew. Out of respect for each other and themselves, you notice they're all wearing their masks.
Yeah.
So thank you, Chris. Any other questions? We have a diploma for you. We have a lot of things for you, but we can't give them to you in person, obviously. Right. Any other questions, folks, from my residents or faculty?
Chris, it's Lewis. Thanks for being on Grand Rounds with us today. Great seeing you as always. Really, congratulations for a tremendous amount of work in a short period of time, and I'm really impressed with this. Can you tip your hat at all about any data that you've collected in terms of what you're seeing in terms of reinfection rates?
Yeah.
Just keep it between the 71 of us here, if you don't mind.
Yeah. We have not seen any clear reinfections. I think we've just not monitored long enough to really see that. But we have seen a number of patients develop odd complications late. A number of patients, 5 or so, ended up having pulmonary emboli that they developed late in their course. One patient even there was a lot of media about him. So I think the odd and renal failure as well, occurring late in the course. I think people think those are happening as a result of microthrombus forming in the small arteries of various organs. As a result of that, and also kind of the general research on anticoagulation in COVID, Jay Mako initiated an anticoagulation protocol at Sinai, which I'm curious to hear if you guys are doing this as well, but patients who are peri-intubation will be started on anticoagulation prophylactically, but full dose anticoagulation. So we really have seen kind of those odd outcomes late, a few weeks into the course. I think that's really major. And the second major insight is that we've been seeing a lot of patients have waves of illness. This is not like the flu where you have it and then you're done. You have it and then you have it again and you have it again, you have it again. And that's leading to a lot of anxiety. And with some patients, even, these late problems. So keeps us on our toes, evaluating a patient who says they have chest pain, pleuritic chest pain for 40 days out. It could be a PE, so keeping that in mind.
Yeah, it's so interesting that, as you've talked about and a lot of others nationally about the differences in stroke rates and presentations, and the hypercoagulability issue has been quite variable around the country. And as you know, the West Coast hasn't quite seen the same rates as the East Coast. And I think it's a different transmission of disease, burden of viral load, something dose related, perhaps. There's all these things at play, but can you comment on that?
Yeah, it could just be a numbers game. I think more people had COVID in this region. So we might have seen that small increase in young people with mild symptoms or being asymptomatic with COVID having large vessel occlusions. Maybe you need large numbers to see that small percentage increase of risk. I did also see an article the other day about evidence that the virus is mutated. So like you suggested, there are different strains at this point. And what was proven in that article I saw was that there's a different R0 for those strains, where you've got one strain that's much more transmissible than the other. And that the new one, unfortunately, is the more transmissible one, of course. So I think you're right. I think there are different strains going around, and we're going to learn a lot about that, I'm sure, as people are genotyping the strains in different regions. I think that there's a lot to learn about, a lot to be learned from the symptomatology, and that the symptom course probably correlates with some level of immunity. And I mentioned that clinical collaboration with the antibody testing group. We're really looking forward to pairing our data and getting all our patients tested so that we can correlate symptom course with antibody titers. And then maybe from symptom course predict with some accuracy the likelihood that someone will be immune. There was one paper from China a few weeks ago that showed that patients with severe COVID were more likely to have higher titers than patients with mild COVID. Kind of makes sense, but that hadn't been proven before. But that's definitely a fact now. And I think that in the mild COVID group, there's going to be some level of symptomatology that will predict immunity.
Chris, I'd be remiss if I didn't ask you a business question, because I'm finishing my MBA in a month, and you're basically in a technology app space, even though it's healthcare, and the tenets of success really are, is it copyable? Do you solve a problem, and can you do it better than everybody else? Those are really sort of the three things that every successful company has to meet in a technology space. And it seems like the pattern for apps and app-related business is becoming the dominant design. If it's a winner-take-all kind of a problem, like Kinza, why is Kinza famous? It's an extremely copyable idea. Anyone could have written that code. It's not IPable, that sort of stuff. And so usually growth at any cost is kind of the typical play for apps and technology-related things. In that regard, are you looking at going to the next level of funding to kind of blow things up a little bit?
Yeah, that's definitely going to be necessary. And we're thinking along that path while staying within the university setting for the moment. I think there's a lot of advantage to being in the university in this specific case. There are a large number of RPM programs, remote patient monitoring programs, that have been around since the codes came out. And I challenge anyone to name one, because none of them have really caught on. But they have great products that are better than what we're using, and they're funded by VC firms, but there's just really no uptake. And I think that the reason why it's an advantage to come from the university with this is it doesn't have to be perfect to get it going and to enact it clinically when coming from inside. But when you're coming from outside, you really have to have a polished product that's got some credit behind it, and it's tough to build that credit initially coming from the outside as an app company into the medical space. But coming from the inside, and this is just my experience over the past month, I don't have any experience in app development before that. There's a lot of interest in collaboration and working together from university to university, and we do have a lot of interest from other places who, right when we have this next program, next app, they're going to start using it. And we're collaborating for free with everything for now. So I think that I see exactly what you're saying. I think that the apps in medicine, haven't really caught on, and I definitely in neurospace, other than really one or two, I can't really name any. So I think that it's because the cost of coming into a university is hard, or into a hospital setting. But I've seen a major advantage from coming from within.
Yeah, and free advice is worth exactly that. But I would say that, I always struggled where crowdfunding programs would be beneficial, but this seems like the ideal model for getting started with crowdfunding, like Kickstarter and so forth, because gosh knows you're going to have huge, popular support on all this sort of stuff. So yeah, good luck with it.
We couldn't have gotten started without some really strong philanthropy. And, I'd never really engaged in that before. I didn't think that it would be something that would move us along, but it got us the money necessary to get the pulse oxes, which we wouldn't have gotten otherwise, and wouldn't have built the credit for the program, in the eyes of our colleagues who see that as kind of the piece that's added. In my experience, the piece that's added is really the symptom mapping, and pulse oximetry really plays only a small part of that. But to gain traction, we really needed that, and being able to raise money philanthropically made that possible. But I think, yeah, definitely at some point in the very near future, we'll have to make some you know, business decisions about raising money.